Hello, my name's Laurie McLeod-Mills, and today we're going to be talking about patient care for people with disabilities and additional needs. So the purpose of this session is to introduce you to patient care for patients who have disabilities and additional needs, and also what you need to do when you're interacting with their families. At the end of this, you should be able to understand physical and cognitive disability and visual and hearing impairment. Describe communication barriers that impact persons living with disabilities. Be able to apply communication and patient care strategies to care for people with a disability. And describe ways to adapt patient care interactions for a person with a disability. So first of all, we're going to start right back at the start and have a discussion about what is a disability. So the World Health Organization in 2007 published what I think is a really lovely definition of a disability. Disabilities is an umbrella term covering impairments, activity limitations, and participation restriction. An impairment is a problem in body function or structure. An activity limitation is a difficulty encountered by an individual in executing a task or action, whilst a participation restriction is a problem experienced by an individual in involvement in life situations. And this umbrella term covers everything from physical impairments to cognitive impairments, and we're going to delve into those a little bit deeper. So just some facts for you, and I'm sorry, these are from 2016. I've been unable to get an update on these statistics, but here are some disability facts for you. So in 2016, the world population was 17.5 billion people, and over 1 billion or 15% of that population had a disability. Of that 1 billion, 110 to 190 million adults, or 11 to 20%, have a significant disability which affects their functioning. We're going to drop down from a global scale to an Australian perspective. So the current Australian population in 2015, when I got this data, was 24 million people. Over 4.3 million, or 18% of the Australian population, have a disability. And in 2015, 281,000, or 8.6% of those people with a disability reported experiencing discrimination because of their disability. And I think that's a really sad fact, that of such a large percentage of our population, people still, in this day and age, with the information that we have available to us, are still reporting that they are experiencing discrimination as a result of their disability. Young people in the category of 15 to 25 years with a disability report the highest incidence of discrimination, about 20% of that group. And that's also very sad. So things to be aware of is that a disability may be permanent or it may be temporary. We're going to talk about particular types of disabilities in the next few slides, and that's where you'll be able to form a picture in your mind of the difference between something that is permanent and something that is temporary. It might be congenital, so someone was born with it. It may be something that's progressive, that over a period of time the symptoms become worse and the impact on the person's life is far more extreme. It may be acute or it may be temporary. It may be obvious or hidden. And that's something that's really important to remember, is that if someone reports to you while you're working in a healthcare environment that they have a disability, they have something that impacts on their ability to interact with you, impacts on their ability to access care, just because it's not a physical disability does not mean that it doesn't have the impact that the person's describing. And the sorts of things that I'm talking about is someone who has a cognitive disability, something like autism, or someone who has mental health issues. And we were talking about that just a few weeks ago. Someone who has acute mental health issues that are affecting their ability to interact with other people, their ability to get on with their day-to-day tasks, that is a hidden disability. So a disability is not just a health problem. It's a complete phenomenon. It reflects the features of the person's body, but also the society in which they live. So somebody may have a physical disability, but how that impacts on their life actually is determined by the society in which they live and the support structure and the acceptance of someone who has a disability. And just the final piece of information for you is that people with disabilities have the same health needs, if not in some cases more health needs than someone without a disability. But they also need to access things like immunisation and cancer screening. And the World Health Organization statistics in 2016 stated that that's something that we're actually not very good at doing. We focus on the health needs of a person with a disability around their disability, and we often then forget things like immunisation and cancer screening also need to be accessed by those people because they have the same needs with regards to that general healthcare. Now we're going to have a look at what are some examples of disabilities, and I'm sure within these groups you're all going to have a number of ideas about what fit into the characteristics of physical disability, cognitive and intellectual disabilities, visual and hearing. The last two I think are very obvious. So some examples of physical disability, I'm talking about someone who is an amputee, someone who is a hemi, para or quadriplegic. And if you've not heard the word hemi before, hemi refers to one limb. So someone who has hemiplegia of their right arm, only their right arm is affected by this. Someone who is a paraplegic obviously is related to the spinal cord, and that involves both lower limbs. And someone who is a quadriplegic has lost function of both their upper limbs and their lower limbs. But a physical disability may also be a temporary disability. I'm talking about someone who has a significant fracture of a limb or or their spine. They will get better, and the impact may be nothing, the impact may be minimal, but at the time of their fracture or shortly after, they actually have an acute disability that is temporary. And so someone may need increased amount of patient care during that period of time, and after their injury, once they've managed to go through rehabilitation, they wouldn't need the same level of patient care. Someone who has a cognitive or intellectual disability, some things that come to mind for me when I think about that are stroke, Down syndrome, autism and dementia. And you'll see there I've put sort of a bit of a mix. So stroke is an acute cognitive disability which is caused by either a blood clot or rupture of a blood vessel in the brain. So the person may have been fit and well before their stroke occurred, and as a result of the damage done because of the loss of blood supply to their brain during that period, they end up with a cognitive disability. Someone who has Down syndrome, which they are born with, and there are physical disabilities that are also combined with the cognitive disabilities of someone with Down syndrome. Someone with autism, where their cognitive and intellectual disability is hidden because their physical features are that of someone who has a normal appearance. And then something like dementia or Alzheimer's, which is actually a progressive disease. The early stages of dementia and Alzheimer's, I think we're getting better at it, but are difficult to identify. And as the disease progresses, its impacts on the person's life becomes quite a significant thing. Visual impairment, so someone who is completely blind or someone who has partial visual impairment. So there are a number of people in the community who are 100% blind, they can't see a thing. And we have other people who fall into that same category who maybe have 95% vision, or their vision is blurred, they can see some things but not others. They could be walking down a hallway and they would have an idea of where the rail was on the wall, although they couldn't see it clearly. Or we might have someone who has something like cataracts, where their visual field gets smaller and smaller and they can actually only see almost tunnel vision down the middle. And we're going to talk about the different types of visual impairment. I'm actually going to give you a link to a website that allows you to really understand the different types of visual impairment that people are living with in the community. And finally is hearing impairment. So deafness, again, much like the definition of blindness or visual impairment, some people may have are profoundly deaf may be able to hear absolutely nothing at all, or some people may have some degree of hearing. And I'm going to again give you a website to access, because that hearing loss is not just volume. It's actually to do with the sounds of words and the frequency of sounds. And so it actually means that even though maybe somebody can actually hear, if they've lost the ability to interpret the frequency of different sounds, it means that the meaning of what you're saying to them is actually altered. And I'll give you a website where you can actually have a listen to that as well. We may have someone who's got a conductive hearing loss, which is temporary, maybe as a result of surgery or injury to the ear, but that's temporary and they'll get it back. Or sensorineural hearing loss, which is, it's actually the brain's interpretation of the sound that is a problem. And so that's actually to do with the nerves within hearing, and actually affects, again, different sounds that the person could hear. It's not just the volume. So all of those things that I've just described have barriers to us as healthcare professionals in providing effective communication if we don't understand how to change our communication and change our patient care. If we understand that, and we understand some techniques to alter our communication and our patient care, then actually they're not barriers to us having effective communication or patient care. It's when we don't understand that we have those barriers. So some things that have been described by people with disabilities that are barriers to effective communication are things like environmental factors. And this you may or may not have control over in a healthcare environment. Noise levels. So if you've got equipment or a surrounding environment that is noisy, and you've got someone who's got a hearing loss, it may make it more difficult for them to actually listen to what you're saying to them. We've got equipment or staff needing to be behind radiation protection. So within radiation therapy, they're actually out of the room during the treatment. Or we may have patients who've got particular masks on for positioning that mean that they can't move their head, and then they can't actually look at the face of the radiation therapist who is talking to them. Or we've got equipment that's in the way. Low levels of lighting. So in the radiation therapy environment, we actually use laser guidance, and so the rooms often have very low levels of lighting, and that can make it more difficult for someone who needs to lip read or to read facial expressions of the person that they're communicating with. And these are environmental factors. As I said, sometimes we have control over these, sometimes we don't. There are organisational factors. Some of these include strict appointments and times. So if we're not aware that somebody has a disability and we make their appointment time for 30 minutes, and to actually provide good patient care to this person, it might take us 45 minutes. So either the staff have to accept that and they work to the time schedule that suits that patient and gets the patient the outcome that they need, or they try and hurry the patient along, and that limits their ability to actually modify their communication or patient care. We might have things like a lack of resources. So healthcare organisations have interpreters available, but maybe the interpreter is not available on that particular day, or the interpreter is only available by phone, and that's not actually helping with what you need to achieve in terms of your interaction with the patient. We might have hearing aid induction loops, which allow the person to directly feed into what you're saying, and it goes directly into their hearing aid. Maybe it doesn't exist in the department that you're working in. So again, this is called a lack of resources. This is an organisational factor that affects us from being able to provide the best patient care that we can. And it may be something like a lack of staff training. In my 20 years within healthcare, I've only actually ever done one day of education around communication and patient care for those people with a disability. And I think that's a sad thing. I think it's within healthcare, it's something that we don't put a lot of value on in terms of continuing professional development. And then the last thing, which is something that I think can certainly be overcome, and you as students, I'm hoping will be taking this on board, and when you get out there to clinical placement in the years that follow, you'll be able to have a look at the way the staff are interacting with patients with disabilities, and you'll be able to work out whether or not that's effective or not and what you might do to change it. So staff attitude, so staff being in a hurry, they're behind on their schedule, there wasn't enough time, the previous patient took too long, or it may just be that these staff are reluctant to spend extra time with patients. Staff who are reluctant to have carers or family in the room, and I see this so often where staff are like, well, we know best, we know how to look after this person, and they're pushing the family or the carer out of the room so that they can get on with the job because they feel that having that person in the room actually impedes them being able to get their job done effectively. And I think in many, many cases, actually having the family member or someone who knows how to look after this person, they do it day in, day out, actually is very valuable to have them in the room with you. And the other staff attitude is negative stereotyping, a lack of knowledge or assumptions about people's abilities. I have a friend who is a quadriplegic. Now, he is a very, very competent man. He's a project manager. He's the only paraplegic ever to actually fly a plane around Australia. He's managed to hand paddle the length of the Murray River in a fundraising effort. And he said to me the number of times that he has been in to have healthcare procedures performed, wherever it is. And he said he comes across people who say, can't you just get on the bed? And he's like, I'm a C1, C2 paraplegic. I can't even lift my hand up to my face. I can't get myself on the bed. And he said this is people's assumption that because he can actually physically push a wheelchair and he can talk to you, he's a very, very intelligent person, that he is not helping to get onto the bed when he should be able to lift himself up or make an effort at least. And he said it's actually these negative assumptions that the person with a disability is trying to be difficult. And he said in most cases we're doing the best we can to try and help you to get the job done because we want to maintain our dignity and we want to get through the procedure as quickly as we possibly can. So now we're going to focus in on some of those disabilities that we talked about at the start. And the first one we're going to look at is blindness or low vision. So as I said, vision loss at the start, some of these disabilities may be congenital, so the person's born with it. It may be progressive, like this example that I've got here. So on the top left-hand corner, we've got someone's normal vision. Someone who is in the early stages of glaucoma, we can see that tunnel vision is starting to come in from the periphery. Advanced glaucoma, the person's lost about 40% of their visual field. Moving on to extreme glaucoma, where they only have about 30% of their visual field left. And that's really, really unfortunate because there might be some really, really important information for that person in the periphery about an oncoming vehicle, in this instance, another person, whether or not the traffic lights are red or green, and it has a huge impact on the person's day-to-day living. So that's a progressive. There may be sudden things, so the person might have an illness or an injury, and as a result of that, all of a sudden the person goes from being a sighted person to having either very, very low vision or no vision. And that is a huge... I've got a friend who is, as a 17-year-old, woke up one morning and had gone from normal vision overnight and just having a bit of a headache to 98% visual loss the next morning. And for him to be able to go from life as a sighted person to an unsighted person was a huge change, a huge learning curve for him. As you can imagine, very depressive for a 17-year-old boy to all of a sudden in the middle of year 12 wake up and not be able to see. He has done a fantastic job. He has gotten on with life. He's actually a motivational speaker now and doing very, very well for himself. But that is an example of something that could be a sudden visual loss. Or there are other examples of this, and I've put a website in here which is from the Fred Hollows Foundation, and it's actually a sight simulator. So you can go into this, you can find, using Google Maps, an image of something that you know the front of your house, university, or something like that. And then you can actually play with different eye diseases and the varying degree of that, from sort of normal vision through the early stages to extreme stages of it, and it will give you a bit of an understanding of how the visual field changes for different types of diseases. So if you have a patient who comes to you who has a visual impairment, these are some things that you can do to improve your patient care and your interactions with that person. The first thing is remove clutter from the room. If the person's going to move around the room safely, they need to make sure that they're not going to bump into things. You need to orient the person to the room and use directions such as left or right from the person's perspective. And I've seen this done wrong a number of times, where the healthcare practitioner will be standing there and they'll say to the patient, "Oh, over here to the right is such and such," but they're facing the person. It's actually the person who has the visual impairment. It's actually to their left. So when we are using directions to describe the room, it needs to be from the perspective of the person that you're interacting with, and you should describe distance in meters. People who have a visual impairment are taught to have an idea of distance in terms of meters, and so they'll know actually how many steps they need to take. And so if you can actually describe things in meters, and from their perspective, they'll actually have some idea of physically what's in the room. When you're giving assistance to someone who has a visual impairment, offer them to hold on to your elbow. Don't hold on to their hand and pull them along. Offer them to grab hold of the inside of your elbow, and you can walk along together at a reasonable pace. If you're coming into the room, or you have someone else coming into the room and you're interacting with someone with a visual impairment, you need to announce your presence. Don't just walk into the room and start talking to them, or don't be in the midst of a conversation with them, be knowing that someone else is standing there, and then all of a sudden start having a conversation with the other person who's in the room. So you might, for example, walk into the room and say, "Hi Fred, my name is Laurie. I'll be looking after you today." You move forward with your interactions with Fred. You do patient identification. You start talking about what you're going to do in terms of patient care for the day. And then someone else walks into the room. Instead of just starting your conversation with that, you say, "Oh, Fred, I need to let you know my colleague Tanya has just walked into the room and I need to speak to her for a moment. Is that okay?" Fred says, "Yes, it's fine." Then you can turn to Tanya and have a conversation with her, and then let Fred know when you finish talking to Tanya and say, "Oh, look, Fred, we've finished that conversation. Let's move forward with what we were talking about before." So don't have Fred just standing there thinking that the conversation you're having with Tanya is related to him, because he can't actually see the other person in the room and he can't see you turn and talk to them. You need to make sure that you tell the patient what you're going to do before you even start. So it needs to be a description of what you're going to do. And you shouldn't touch the person without seeking consent. "Fred, I need to move you onto the table over here. It's quite narrow. It's about a meter in front of us. Are you happy if I help you to move over?" Fred says yes, and then you move over to the table together. And the last thing fits in with what we were discussing at the start in terms of your presence in the room. If you need to leave for any reason, you also need to let Fred know that you're going to leave and about how long it's going to be before you come back. If you're delayed in coming back, you should go and pop your head in the door and say, "Look, Fred, I've been delayed. I need about another 5 minutes, and then I will come back to you." You can't leave the person sitting or lying in a room with no ability to get themselves out of that room, because you haven't come back and they're starting to get worried about what's going on. So in terms of medical radiation, it's a lot of patient care, but I'm making this specific to medical radiation, you need to consider how you're going to assist the person with safe options for patient transfer. So from standing to laying on the treatment table in radiation therapy. If the person's in a wheelchair, you're going to have an added complication of from wheelchair to standing to treatment table. Or if the person's laying on a hospital bed or an ambulance transport bed and they need to be moved across to the table, we have a process called a horizontal patient transfer, where we roll the patient up just slightly, we put a slippery board behind them and we move them from one bed to the other. Now that's a very odd feeling for anybody. It's even more disturbing if you're an unsighted person and all of a sudden you're moving horizontally either to your left or your right and you have no idea what you're being moved onto. So there are some ways that we can improve that, and once you get into clinical practice, whatever that is, hopefully the people you're working with will demonstrate to you the best way to do that. Communication, this is a rehash of what we talked about before. You need to assist patients to understand their surroundings. And a good way, as well as the left and right, is to use a clock face to describe relative positions of objects. So if something is maybe at a 3 o'clock position or a 5 o'clock position, it gives you a few more options than just simply left or right. And again, describe it from the person's perspective. Ensure that you inform the patient about equipment or narrow tables. Things like feel for the edge of the table or feel for the back or the arm of the chair so that the person actually has some idea of where they're going to sit. I like to get people with a visual disability to hold both arms of the chair so that they know where either side of the chair is. The same for the edge of the table whilst I'm getting them onto the table. You need to describe the examination in detail, and far more detail than you would for someone who was sighted. What are the steps going to be? What sounds the patient may hear during the examination? Who else is in the room? And if there are any requirements for suspended respiration, so either breathing in and holding, breathing out and holding, or just stopping, then you need to rehearse those breathing requirements with the patient. Okay, moving on to our next disability. So deafness, or people who are hard of hearing. And this is that website I said that I would get you to go and just have a play around on. So the StarKey hearing loss simulator actually shows you within vocal frequency. There are some frequency ranges that start to go in the early process of hearing loss, and this is about conductive hearing loss. And when those sounds for the vowels and the consonants are removed from a sentence, it can actually make it very difficult to understand what the words are that someone is saying to you. And I can't describe it to you any better than you going to the simulator and having a play around with different ranges of deafness. Now, it is the one paragraph that the person is reading, so it's not like the Fred Hollows one where you can go and put in some text that you like yourself. It is just one paragraph, but it does give you a really great picture of the range of vocal frequencies and which ones are lost early on in hearing and how that would sound if you were listening to it. And then also you can add in things like noisy backgrounds and stuff like that, so you can have an idea then if the person's got a hearing loss, then you add a noisy background in, really what they can possibly hear. I think it's a great simulator for healthcare professionals to be able to understand. So when you are providing patient care for someone who is deaf or has a hearing impairment, it's really important to understand that the person actually has a right to choose how you communicate to them. So there is a thing called the Australian Charter of Healthcare Rights, and these rights describe what a person receiving healthcare in Australia can demand from a healthcare service and also from a healthcare practitioner. And one of those is the right to choose how you're communicated to. So there are some people who are deaf or hard of hearing that can use sign language through an interpreter, and that is called the NABS, and it's actually a service that is available to all people with a hearing impairment. And so I've had a number of examinations where I've had a person turn up and they have an interpreter from this service with them, and the examination moves through really, really quickly. I've had other patients turn up and they've had a family member with them who acts as the interpreter, and that also works really, really well. I've also had people who have turned up without any interpreters, and those examinations also worked smoothly. We just wrote notes to each other. So I explained in written form and drew a few diagrams about what was going to occur during the examination, and the person was able to ask questions and I was able to answer them. Lip reading is something that some people who have a hearing impairment can do. And there are also other things available within healthcare called alphabet or picture boards. And these are coming into play. I've seen them more frequently, more recently, and these are picture boards that allow the person to either point to letters of the alphabet or point to different pictures that relate to the area in which they're receiving healthcare. So, for example, there's a dental-specific picture board, there's one for an outpatient setting, there's one for an emergency department, there's one for a general practitioner, and they have pictures on them and text that describes the sorts of things that the person would need to understand whilst they were communicating with the healthcare professional in that environment. It's really important when you're dealing with someone who is deaf or has a hearing impairment that you understand that hearing aids make sounds louder but not necessarily clearer. And when you look at that star key simulator, you will understand what that means. So if someone has lost the specific ability for their brain to interpret a vocal frequency range, just wearing a hearing aid is not going to get that back. If it's that the sounds are not loud enough and their brain can still interpret them, then having a hearing aid is going to make them be able to hear it, but it won't make it clearer. You need to make sure that the patient has them turned on and that they have battery power and they're correctly fitting. A number of people who wear hearing aids find them very, very annoying in noisy environments, so they turn them off. They're sitting in a waiting room, they're sitting on a train, somewhere where there's just a whole lot of background noise going on, they just turn them off. I'd love to be able to turn my ears off sometimes when there's a lot of background noise going on. So make sure before you start to communicate with the person, if they are going to use their hearing aids, that they have them turned on. If it's an elderly patient, make sure that they have battery power, that they haven't forgotten to charge them or the batteries haven't gone flat, and make sure that they're correctly fitting. There are some people who have difficulty actually getting them in properly, but if you can wiggle them around for them, you can actually get them to fit properly, and then you can communicate with the person for the rest of the procedure. If hearing aids do need to be removed for the examination, you need to make sure that you have communicated all important messages with the patient before they take them out. And make sure that you have cues for the patient for things like breathing instructions, if they need to do that during the procedure. One that I know works really, really well is if you need the patient to hold their breath, you turn the lights off in the room, the treatment room or the examination room, and then you turn them back on when you need the person to breathe again. That's a really great one. Very, very simple, very, very obvious to the patient. If someone's wearing a hearing aid, it's really important that you don't shout at them. And the person may still fully understand you even if they're missing some words in the high frequency ranges. People who have hearing impairment are really, really good at interpreting what somebody is saying to them, even if they're missing some of the sounds or some of the words. It's important that we are prepared to rephrase what we say, not just repeat it. So if someone has misunderstood what you said, it may be that a lot of the words that you have used have sounds in those high frequency ranges that they can't understand. And so just repeating yourself, they're still not going to get a clear message. You actually need to rephrase what you have said, and maybe they will pick up some of those missing pieces of information. So how can you improve your patient care? Number one, reduce the background noise. A bit like we said, if someone's got a visual impairment, remove the clutter from the room. Well, this is like removing the clutter. So if you can try and reduce background noise, you might need to ask other people to be quiet. If the room has 2 entrance doors to it, you might need to close both of those doors to reduce background noise. You need to make sure that you don't shout, but you speak more loudly than you normally would. Speak slowly and distinctively. I think this one's pretty obvious, but I am going to state it. Do not chew gum at the same time that you're trying to communicate with the patient. And you may need to pause more frequently than you normally would to allow them time to process what you've said before you move on to the next piece of information. It's best if you stand about 1 to 1.5 meters from the person. So don't stand right up in their face, but also don't stand a long way away, and that you face the person directly, and that you use non-verbal communication such as gestures with your hands, demonstrations, as well as the verbal communication that you're using. Have the person repeat vital information. So if you have said something to a person and it's really vital information, ask them to repeat it back to you in a polite way so that you don't make it seem as if you think they've got a cognitive disability. So have them repeat the vital information. And just that last one that we talked about before, be prepared to rephrase what you've said rather than just repeat it. Now, it's really important, just in summary, for people with a visual disability and a hearing loss, and also with a physical disability, that we don't treat people as if they also have an intellectual disability. So I have three friends and family members. I have a cousin who is profoundly deaf. I have a friend who is quadriplegic, and I have a friend who has the young man I was talking about before, who is has 98% vision loss. And when I speak to them about patient care experiences on a regular basis, we have conversations about them. The number one thing they say is that people treat me as if I have a cognitive disability as well. They speak to me like this, and they say stuff in a really simple way. Now, I can tell you all three of these people have professional jobs. My cousin, who is profoundly deaf, is a graphic designer. My friend, who is the quadriplegic, is a project manager. And the young man I spoke about who has a visual disability is a professional speaker. So they all have absolutely normal functioning brains, and they don't need to be treated as if they have a cognitive disability. So we need to be careful with our patient care that we are only changing what we need to change to assist the person with the disability that they have, and not assume that they have another type of disability as well. Okay, moving on to physical disability. So just here are some examples of physical disabilities. Someone who's an amputee, as I said before, someone who has a hemiplegia, so that's just one limb. Someone who is a paraplegic, so both lower limbs, or a quadriplegic, which is all four limbs. Someone who has a significant fracture to a limb or their spine. Someone who has a progressive central nervous system disease like MS. MS actually is a physical disability. The neurological pathways between the brain and the limbs start to actually degrade. Person loses their ability to actually control their body. It's a physical disability, even though it is a progressive central nervous system disease. Someone who has chronic fatigue syndrome has a physical disability. Someone with spina bifida or cerebral palsy, which are congenital diseases, have a physical disability. So some challenges for people with a physical disability in terms of accessing healthcare. One of them is transport to and from services. So how does the person get themselves to and from their healthcare appointments? Usually they have to rely on family members. They might have to rely on public transport. I'm thinking, taxis, Uber, that sort of thing. It may be that they require specialised transport, such as transport ambulances and things like that. So their first challenge is, before they even get their foot in the door, it's actually getting to the healthcare facility. And then sometimes they get to the healthcare facility and they have difficulty actually physically accessing buildings. So if there are narrow or heavy doors, maybe they have difficulty opening them. Or if they're in a wheelchair, things like stairs, narrow or steep paths might be really difficult. Narrow paths in waiting rooms. And what I'm talking about is when the chairs in the waiting rooms are really, really close together, and it's even difficult for someone who is able-bodied and walking to be able to walk between the chairs in the waiting rooms, but we clutter too many chairs in the waiting room and the person can't actually physically maneuver themselves around them. And the other one is reception desks that are designed for someone to stand at chest height. If someone's in a wheelchair, then it's going to be above the height of their head. The next thing may be a lack of lifting, support or mobility equipment at the healthcare facility. So community healthcare facilities are the ones who are sort of, I guess, most to blame for this. Is the person turns up, the GP says to the patient, I need to get you up onto the examination table. Oh, actually, we don't have any way of doing that. I'm going to have to get you to go away and go somewhere else because I don't have any mobility equipment to allow me to safely get you up onto an examination table. So that's something that we need to be aware of, is within the facility that we're working, do we actually have the equipment to be able to help someone who has a physical disability? So the other thing that can sometimes happen is that we get this equipment and then we train staff initially in how to use this equipment, and then we forget to train the new staff who come in the door. So maybe 2 years ago we put in a lifting machine, but we haven't trained any new staff in how to use the lifting machine, and on the day that the person turns up we go, oh well, hang on, we've got a lifting machine but no one who's here knows how to use it. So we need to make sure that from a management perspective, that if we have that equipment, that everybody who comes in the door who needs to use it is trained and able to use it safely. And then the final thing here is staff attitudes to people with a physical disability. And as I talked about my friend Dave, who's the quadriplegic, he said he's had a number of occasions where he's had healthcare staff say to him, oh, can't you just get yourself up on the bed? He's like, no, I'm a 95 kilo quadriplegic. I can't get myself out of bed, let alone up onto your examination table. And so he said a number of times he's encountered staff who believe that he's just trying to be difficult and not going to get himself up onto the bed, even though they think he's able to. So we need to be very careful about our attitudes towards people with a disability. I'm going to give you some tips here about patient care and communication. And as you see down here, the references I've used is David Jacker. So Dave is my friend who's a quadriplegic. If you have a few minutes, it would be great to Google him. So Dave, as I said, is a quadriplegic who has not only learned to fly a plane, but has flown solo around Australia. And there's actually a movie called Soar, which is available online, which is his story about learning to fly. He's a phenomenal individual. He's also provided me with some really great ideas here about the best techniques for patient care and communication with someone with a physical disability. So if you're talking to someone who uses a wheelchair, try and find something to sit on. Don't stand up over the top of them. Don't sit on the side of their wheelchair. Just grab a chair. Grab a chair, sit down next to them, or sit down on the examination table so that you're around about the same height. You have a think about if you're sitting in a chair and someone comes and stands up over the top of you, it can seem like a little bit intimidating. If that person has healthcare information to provide you and you're sort of leaning back because you feel intimidated, you're less likely to actually be able to interact with that person and listen to what they're saying. That's the first one. His second one is do not assume that a person with a physical disability also has a cognitive disability. And I did mention this before, but he said it's very, very common that people see him in a wheelchair, that they assume that he also has a cognitive disability, and they start to communicate to him in that way. And he said it's very, very embarrassing for him to have to say, just stop for a second, there's nothing wrong with my brain. He said it's embarrassing for both of them, but he can't let the person go on not giving him enough information because they assume that he also has a cognitive disability. A person's personal space when they have a disability also includes their wheelchairs or crutches or a walking stick. It becomes part of them. Most of them have relied on this method for them to be able to get around, or this equipment for them to be able to get around for years and years and years. It becomes part of them. So don't touch them or move them without asking. Particularly don't just grab the crutches and throw them in the corner because people with disabilities feel like that's actually become part of them. So do be respectful of gait aids and wheelchairs. Describe what you need the person to do and ask them the best way to achieve it. So you need to work together to assist the person safely to transfer to and from equipment. You may need to be creative. And one thing that Dave said to me is really, really important is that he has come across so many different situations. If you describe what he needs to do, he can tell you, oh, that's just like me getting in and out of this. That's like me getting in and out of that. And the best way to do it is this. Or if you go and get another person and that person stands here, you'll be able to assist me to do this safely. So just, you might need to be a bit creative and not just say, we're going to do this. And sorry, I have got the word radiology in here. This was a modification of a previous lecture that I had done. One thing that Dave said is really, really important is that just trying to get ready in the morning to get to your appointment, whatever that be, can be a huge challenge. It takes lots of coordination, particularly if you can't drive yourself, and it's physically demanding. So don't have the attitude that the person with a physical disability is trying to make your life difficult when they say they can't do something. It's taken them a lot to get in the door. And on that, people with physical disabilities have jobs. Don't delay them. They might be trying to get to work on time too. So it might have taken a lot of coordination and be physically demanding for that person to get up in the morning, and they've made their appointment really early because they've got to get to work on time. So don't delay them and say, oh, I'm just going to do this patient and then I'll get to you because you're going to take up more time. If the person has an appointment time, then do try and stick to it as best you can. Okay, moving on to our last group here. This is people with developmental, cognitive, or intellectual disabilities. I've just put a link in here to a lovely YouTube video made by some young people with Down syndrome. It's really, really lovely. If you've got 5 minutes, I suggest you watch it. People with Down syndrome, they're people too. They're fun, they're creative. A number of them attend normal schools with additional support these days. They just want to be themselves. They're not special needs people. They just have different needs. And I think this video, if you do go to the YouTube channel, the video just sums it up really, really nicely. And it was made by the young people who were acting in the movie. They wanted to spread a message about the fact that they are normal people as well. Okay, so moving on from physical disability, now we're going to talk about developmental disability. So developmental disability is related to physical difference or a disturbance in the function of the brain. So it may be as a result of perinatal or prenatal events, and that's where we're talking about things like congenital malformations in the brain or DNA. So changes in DNA, we're talking about Down syndrome is probably the most well-known of all of those, but there are things like Prader-Willi syndrome and stuff like that, which have different common developmental disabilities associated with them, but this is something that's happened as the embryo has been developing. It might be a result of early childhood disease, so maybe someone gets an infection, they have some sort of toxic event or some sort of hypoxic event during birth or something like that, that actually leads them with a developmental disability. It could also be childhood trauma. So I'm talking about things like motor vehicle accidents, near drownings, significant falls, child abuse can all be childhood trauma that leads to a developmental disability. So developmental disability is associated with a lifelong functional impairment. It significantly affects a person's life as it reduces and or delays their ability to understand and interpret the world around them. And it significantly delays traditional learning of things like language. So if you think about all of the things that a child acquires in the first few years of their life, learning to walk, learning to talk, and then the early years of primary school, learning to read, learning to write. If every time you hit those developmental things, you hit a hurdle and it took you longer, add all of those delays together, and down the path, you're going to be 3, 4, or 5 years in terms of development behind your peers of the same age. So those developmental disabilities early on can have a huge impact, and that's why we see a big difference in the abilities of people with a disability later in life when we actually compare them to their peers. So there are 4 groups that I'm going to flag with you. The first one is motor impairment. So think things like cerebral palsy. So the disturbance in brain function affects the ability for the brain to send messages to the body in terms of controlling the body. Cognitive impairment is things like intellectual disabilities, someone who has an IQ of less than 70, and that usually results in difficulty with everyday skills and the acquisition of those things such as language, such as reading and writing. We have social impairment. A really great one that everyone probably knows of is autism spectrum disorders, and it is a spectrum. If you want to delve into that a bit more, it's actually very fascinating to see some of the people who are well-known and famous people who actually have diagnosed autism spectrum disorder. There are people on there like Bill Gates. There are some famous actors and things like that on there. And so the impact on them is their ability to actually interact with people socially. And there's sensory impairment. So this is vision and hearing. So this is, in terms of brain function, this is the brain interpreting the visual and hearing cues. So if we put each of those into a box, we can have, I hope this mouse is going to work, we can have people who have motor impairment and cognitive impairment and a little bit of sensory impairment and maybe some social impairment. So these do not sit in separate boxes out here. We often will find that if someone has a developmental disability, they have a couple of these impairments, and it might be 60% motor and 30% cognitive. But it's not just that they sit in boxes by themselves. If someone has a developmental disability, they often have parts of disability from each of those boxes. So how to interact with someone who has a cognitive or intellectual disability? When you're commencing your examination, do so with a positive attitude. It will actually greatly increase the quality of care that you can provide. And there are a number of published articles that talk about the attitudes of healthcare practitioners and the impact that has on the quality of patient care that they provide to someone with a cognitive or intellectual disability. People with cognitive disability have a broad range of abilities and understanding, so you actually really need to adjust your examination based on that person's understanding and abilities. And this is where having the family members in the room, I think, is such a useful tool for you to be able to actually understand the best ways to communicate and interact with the patient that you're looking after. Communication is usually impaired, and so people with intellectual disabilities have different communication profiles. For example, someone who has Down syndrome will often prefer gestures and body language. So something like welcoming them with a big high five or a handshake or a smile and a really lovely tone in your voice will actually get you off to the right start, as opposed to just talking to the person. People with cognitive disabilities might have difficulty with receptive communication. They might actually understand exactly what you're saying to them, but they can't actually prepare a verbal response. And the family member or caregiver who's with them usually will be able to help you to get them to communicate back to you. Or they'll say to you, they've just said this to me and that means this. So it's not that they're trying to be difficult, they're trying to help you interpret what's coming back your way in terms of receptive communication. And it's important to understand that someone with a cognitive or intellectual disability, it's common for them to also have hearing and vision. So you need to find out from the person who is there as their carer if this is the case, and then you're going to need to adjust not just for your interaction with them because of their cognitive disability, but also because of maybe hearing and or vision impairment. when you're interacting with someone who has a cognitive or intellectual disability, you need to reduce that background noise. It becomes a distraction for them. They often have difficulty being able to focus on what you're saying when there's other things going on. They need their brain wants to go and explore and try and work out what the other thing is that's going on, whether it's music or talking in the background, and then they'll actually have difficulty trying to interacting with you. It's really important that you have the room set up before you start. Consider your choice of equipment. If you need sponges and things like that, positioning devices, have it all set up so that you don't have to run off and go and get that equipment. Consider having 2 staff members, so radiographers, radiation therapists, or a third person in radiation therapy to actually help the examination flow. So that if someone needs to go and get a piece of equipment that you don't have, the other 2 people, or 1 people if you've only got 2, can continue your interactions with the patient and be starting to move forward with the examination whilst the other person goes and gets whatever other equipment it is that you need. It's really important that you understand that valid consent is a legal requirement for any imaging examination or radiation therapy treatment. I know you're going to go and do the ISAP case, and it looks at informed consent for people with cognitive disability. It's really important that you understand that you can't move forward with an examination or a particular type of treatment without informed consent. And it may be from the person, and it may be that you need to change your communication profile so that the person understands and is able to communicate back to you that they consent to move forward, or it's going to be your communication with the carer or the legal guardian of that person to make sure that you actually have obtained informed consent, and you'll be able to go through that when you do the ISAP case. The final thing, and I know this is a lot of information for you. Hopefully you can go back a few times if there's anything that you've missed, and we will review some of this information in the 2-hour lectorial that we're going to do together, is that you look beyond the disability. When you're communicating with the person, when you're providing patient care, they are a person, and it's just that you need to adjust what you're doing in order to accommodate them. It's not that they are a difficulty or a burden. They're actually a really lovely person underneath. They, have jobs. Some of them are studying. They just have a few more challenges to overcome in life. Thank you very much, and I will see you at the lectorial.